About the irreversible electroporation of pancreatic carcinoma. As you can see, I'm not Professor Bassi, unfortunately. He's sorry he cannot be here, but I give you his best regards and please be content with my presence. Is still pancreatic carcinoma an invincible disease? At the moment we can say yes, and these numbers talk clearly. Even if it's still rare, it's the fourth cause of tumor death in Italy. 70% of resected tumors will recur within 2 years, and moreover, 5-year survival is quite poor, 5–10%. One of the things most sad is that resectable patients at the time of diagnosis are just at 20% of the total amount. The remaining part, the 80%, are unresectable, and less than half of them is locally advanced. So locally advanced pancreatic cancer is a big slice of a big problem. It's a stage 3 disease no longer suitable for radical resection. Treatment options are limited. The curing guidelines recommend are mono or combination induction chemotherapy followed by concurrent chemoradiotherapy. With this best treatment, they can reach a median progression-free survival of 6–10 months. A median overall survival of 11–15 months. On the contrary, no treatment got a median overall survival of just 6 months. Then what can we do? Now new weapons are available. Electrochemotherapy, cryosurgery, interstitial laser coagulation, radiofrequency ablation, and irreversible electroporation. The electroporation in the 80s was used as the electrogene therapy to deliver nucleic acids and DNA into cells. In the 90s, they used electroporation to perform electrochemotherapy to deliver non-permeable drugs into the cells. But in 2005, they used electroporation with cellular ablation. What is electroporation? Electroporation means electropermeabilization. If you use adequate electric pulses, you can create an electric field that can open channels or create new ones, modifying the structure of the cell wall. Electroporation can either be reversible or irreversible depending on duration and intensity of the electric pulses applied. The reversible one now means electrochemotherapy, where high intensity and short pulses applied to cell wall cause creation of transient pores through phospholipid layer, from whom non-permeable molecules enter into the cells and rest trapped after closure of the channels, as you can see in this small picture. The irreversible one, it's a kind of cellular surgery. One of the first problems at the beginning of the use of electroporation was that if electric pulses were of the wrong intensity and length, some pores may fail to close or may become too large. So that could cause cellular death due to necrosis. The reversible electroporation uses a generator of electric pulses that create electric field with definitive opening of pores. So cells don't come back to original status and die because of necrosis, maybe apoptosis, it's not clear still. Which are the main benefits of irreversible electroporation? The disruption of cell membrane integrity without pharmacological addition injury. Cells in the ablation region are destroyed, but the underlying matrix is not damaged, so it can be useful if you consider the healing phenomena using the scaffold of the underlying matrix. It's a non-thermal technique, so non-vascular and non-nervous damages are caused. You can do it percutaneously, and it's easy to apply, and it's repeatable. They can be used for huge liver tumors. These are the basis of the protocol ONC 208 that we conducted in the department I work. It's a single-center, single-arm study, a prospective phase 1 study, in which we enrolled 10 subjects in 12 months, but we did it in 6 months, followed up for 90 days. The principal investigator was Professor Claudio Bassi. The study objectives were: the primary one was the evaluation of safety and feasibility of the irreversible electroporation to treat unresectable pancreatic carcinoma, locally advanced, no metastatic diseases. The secondary objectives were evaluation of radiographic response via CT imaging, evaluation of possible downstaging for resectability, and the evaluation of efficacy through a review of symptom scores via the visual analog scale of pain, the QLQ PAN26 and C30 questionnaires of quality of life. Subjects were required to fulfill all inclusion criteria. They were 13 or 14. Among this, the most important were tumor size less than 4 centimeters and measurable, meet criteria for locally advanced unresectable pancreatic carcinoma as radiographically proven or who were initially thought to be resectable, and to be unresponsive to chemotherapy as demonstrated with either CT or MRI. Subjects were excluded from participation in the study if they met any of the exclusion criteria, and among this, implanted cardiac pacemakers or defibrillators, and implanted electronic devices or implants with metal parts in the immediate vicinity of the lesion. On your left, you can see the generator of the electric pulses with the synchronizator of the EKG to avoid that electric pulses can modify heart rhythm. And these are the probes we use. This is the monopolar type, this is bipolar one. These are the mathematical models that underline the procedure. This is the reproduction of this is the reproduction on your right of the area that time by time we saw in the monitor of the generator. It is reconstructed using an ultrasonography done intraoperatively. And it was supposed to be the area that would be destroyed, would be ablated. This is the picture of the first patient we treated using 5 monopolar probes, the 14th of June 2011. And these are some of the procedure features. Median number of electrodes used was 4. We used 9 times the monopolar probe, just 1 time the bipolar one. We performed only 1 associated surgical procedure. In the last patient, it was a double bypass, a biliary and gastric one. No blood loss, so no transfusions. And we reported just 1 procedure-related intraoperative complication. Patient 6 experienced, in fact, hypertensive peaks that led to interruption of procedure, but at that time we had delivered more than 90% of energy. This is a pre-procedure CT scan of the first patient. This is the first day after procedure CT scan. And this is the 30th day after procedure CT scan. You can see maybe fibrous tissue, desmoplastic tissue. It's difficult to assert it. For sure, as you can see in this patient, after 1 month, there is a huge hypovascularized area that is the result of the ablation. This is very interesting because in the last year we tried to extend the use of irreversible electroporation also to local recurrency of pancreatic carcinoma, and this is the PET-CT at 2 months interval. As you can see here, there is no PET signal compared to this. It was a local recurrence in the pancreatic stump. Let's compare radiofrequency ablation and irreversible electroporation. We can say that we are passing from thermal experience to non-thermal perspectives. Which are the benefits of RFA? pain relief, downstaging, increase of overall survival as well demonstrated by Generale and colleagues, and for sure immunomodulation, which are disadvantages of radiofrequency ablation. That so-called heat sink effect, that means that tumor near big vessels with diameter more than 3 or 4 millimeters can be not properly treated because the relatively cooler temperature of the blood flow can transport away the heat from the lesion. Generale and colleagues reported vascular or nervous damages. You can imagine that bleeding in that region of the pancreas is not so easy to control. They reported also abdominal complications like pancreatic abscesses and pancreatic fistula, very difficult to treat, like fistulas with the jejunum or the duodenum, and its unselective action compared to the one of irreversible electroporation that got these benefits. It's a non-thermal action, so no vascular damage. In China, they did irreversible electroporation on the wall of the arteries, and they didn't report any complication. No direct damages, no late damages like aneurysm or thrombosis. No abdominal complications, and its peculiar selective action. And which are the disadvantages? There are disadvantages. The comorbidity of patients, so some heart diseases are not admitted in the pathological history of the patient. Tumor dimensions, is not clear how big can be the tumor, which is the cutoff. We had the 4 centimeter cutoff. Multiple probes are needed, and that can be very dangerous if you consider that region of the body, the head of the pancreas, full of big vessels. And you have to be careful if there are closed metallic stents. Which are the preliminary conclusions? And they are preliminary because we are going to publish the data maybe in September. The procedure is safe and feasible, so no mortality and acceptable morbidity. It's a new tool in the surgeon's toolbox, for sure. It's a new type of targeted surgery, even if more data are still needed. Thank you very much. Any question?
Okay. Actually, this is the open approach for sure is in untreatable with other procedures is at the moment the first choice. However, they showed me an attempt to use it percutaneously. That means you have the contraction of muscles that can give several problems, even when you have to position multiple probes. So I see, of course, this approach at the moment mainly in open setting. It seems to me an incredible, see the premise and the theoretical effectiveness. It seems to me an incredible method to obtain to kill tumor even inside, like as a hepatologist I can say portal vein thrombosis, main portal vein thrombosis. So this would be the first thing that I would suggest. That's a patient that escaped the liver transplantation, escape everything, even if there are several papers dealing with radiofrequency ablation of neoplastic portal thrombosis, and for who perform these procedures is a foolish thing. So theoretically it would work. When you position the 5 probes or the 4 probes, you had to rely with the presence of vessels, or you just don't care because you know that you will not damage the architect stroma of vessels?
You can be safe when you put probes because, well, you have to be careful when you put 5 probes because of the gastroduodenal artery and the hepatic common artery. You know, the arteries that are in that region.
Just in trespass.
Just in trespass, because if you irrigate the energy, you can be safe. You will not damage vessels.
If you make it under ultrasound guidance, you cannot trespass.
Yeah,
unless
absolutely.
you are not able to perform interventional US guided intervention.
Yeah.
But you are able to do that. That's to trespass factor is not a problem. You don't do it because we are speaking about in open with high frequency probe and with large vessels. So there is no, if you don't care if you are 2 millimeters from important artery.
Even if we have infiltration of the artery, of course.
Yes. You don't care if you are 1 millimeter from duodenum wall.
Absolutely.
There is no problem with duodenum because the stroma of the intestinal wall is sufficient sufficient to resist to the procedure and to repair subsequently.
Yes, absolutely. Very quickly. In the patient number 5, we used the bipolar probe because it was difficult to put several probes, the monopolar type. It was small, yes, 2 centimeters, but with the total infiltration of hepatic common artery. So we used the bipolar type, and I saw the patient just 1 month ago. We did it in August. She is quite good, no complications related to the procedure. I think we can consider irreversible electroporation as an option. When you open the patient, you got a pre-op diagnosis of a resectable tumor. A lot of times we open the abdomen and we saw the infiltration of the arteries. You can choose this option for sure.
Problem with nerves.
In literature, they stimulated nerves. They try in the ischiatic nerve, and there are no problems with nerves.
But
they are not damages.
Not stimulated, they're damaged.
They are not damages, so maybe we cannot use this procedure as a pain relief procedure.
The axons, any histologic or electron microscopic studies after on axons?
They got it in the ischiatic nerve. They try to do it. Nerve is less responsive. It's a sensitive and motorial one, and they got no problems with the conduction of the nerve. But so we can say that we cannot use maybe at the moment a reversible electroporation to pain relief as you can do with the radiofrequency ablation. For sure, you can consider it as an option, and maybe we can do it in the recurrence, local recurrence after pancreatic duodenectomy.
Did you perform or did you see to perform any percutaneous or this? And
no.
What do you think about it?
No. There is a huge number of percutaneous procedure. Actually, it's the biggest one from Australia. They did lung, liver, and kidney, but no pancreas. I know that in Naples, that you did it, and but no in a pancreatic tumor. I think Dr. Martin in the US did it. He got the biggest experience in irreversible electroporation. But I think there's no future for percutaneous application of reversible electroporation in treatment of pancreatic carcinoma.
No,
You
no.
need a laparotomy
No,
because you have to be sure.
No pancreas.
Absolutely, but for the other organ, yes. Kidneys, lungs, and liver, sorry.
Okay.
You have mentioned fistula, like complication.
Yes, in the RFA. In order, yeah. In the RFA, we, Verona and with Pesquera Delgada, they reached a huge experience in radiofrequency ablation, more than 200 patients.
Not electroporation.
Not now. No, no. I can tell you for sure that we will publish all the data in September, so you will see all the problems that we had and all the critical points of this procedure.
Thank you.